So as been introduced, I'm Samuel Koo, and I'm a shoulder specialist. This is kind of what I do. I'm an orthopedically trained surgeon, but I chose to limit my practice to shoulders only, and so that's currently what I do. So I only see shoulder patients and treat shoulder patients at this time. And so today, I'm going to just briefly talk about rotator cuff, and I called it the COVID year update because it's been such a crazy year. I'm sure for all of you guys as well. And so I'll try to go over some of this stuff in hopefully an understandable way for all y'all. So we talked about this already. I did most of my training in the Chicago area, but I'm a local guy. So I grew up in Shoreline, Washington, and I went to Shorewood High School. And so coming back here to practice has been awesome. Just coming back home. My wife's from Tacoma, and so both of us are from this area, and so we're excited to be here. And now it's been going on 11 years, kind of crazy to think, since I started my practice here. So today, just basically kind of from a perspective of what to expect, I'm going to just briefly talk about the rotator cuff itself, so you have an understanding of what we're talking about. Then I'll talk a little bit about kind of some new techniques as it pertains to 2020 and what some of us are doing in the rotator cuff, with the rotator cuff, and difficult issues. And then I want to focus a little bit of time on kind of the holistic shoulder surgery experience, because I think these things matter, especially to patients. Your whole experience, not just the surgery itself, I think is an important part of, I think, how we treat and how we have improved treating patients over the years. So rotator cuff tears, as probably a lot of you guys know, it's the most common shoulder problem to be treated in the United States. It's such a ubiquitous problem. You all probably know somebody with a rotator cuff issue, and depending on who you know, it may have been a horror story or it may have been a success story. But in any case, in terms of the anatomy, the rotator cuff is the second layer of muscles that is in the shoulder, comprising of 4 tendons. So they're the supraspinatus, infraspinatus, subscapularis, and teres minor. And out of those tendons, the most commonly torn one is the supraspinatus. And when you hear about tendon tears, that's probably the one that you'll hear about the most often. It has a certain anatomy to it as it inserts into the ball part of the joint, not the socket. And depending on the person, it can change. So not everybody is created equally. And these tears can also happen in different sizes, and that's a fairly important point. Here you see a picture of a fairly, maybe a medium-sized tear, where this whole hole in this area should be filled, but it is not because it's torn. And so you can go from partial tears all the way to what we call a massive tear. And the treatment of these things matter a lot because depending on the size, the options for treatment will vary. Small tears are, just like it sounds. It's a small tear physically. Strictly by definition, we probably go and say it's a 1 centimeter or less tear. And you can see kind of from this picture, this is a picture that's magnified 4 times because that's what the arthroscopy does. And that's a spinal needle that's kind of pointing in that direction. That's a tear. That's less than a centimeter tear. Almost always when treating small tears, people do fantastic. You repair it any which way you want. Again, most people with small tears don't have trouble healing them, and they do well after surgery. Massive tears is a different story. So this is another picture, but this time, instead of being a small tear, you're talking about a really, really large tear. And so strictly by definition, you're looking at tears that involve 2 entire tendons. So for instance, supraspinatus and infraspinatus, or tears that are 5 centimeters or larger. And just because of their size, they also tend to have atrophy and other features that make it very difficult to repair. And a lot of you, or many of you, may know somebody that's been told that your rotator cuff can't be repaired, or it is irreparable, or if it's too big to be repaired. This is kind of the category in which it would fall under. So now talking about kind of important things to know about the natural history of rotator cuff tears. So what happens? So what? I have a rotator cuff tear. What does it mean? And so in general, these are good things to keep in mind. Rotator cuff tears, when you have them, they don't heal on their own. And it's not that they can't heal, but it's just strictly anatomical. And so if you can think about like a rubber band that you stretch out and you cut that rubber band, what happens? I think for most people, you understand that the two ends would retract away from each other. And as a result, they're not anywhere in proximity to each other. And that's kind of what happens to the tendons and the fibers of the rotator cuff when it tears. The two ends actually retract away from each other. And so the ends are not in proximity to each other. So it's not that they couldn't heal, but due to the circumstances and the anatomy of the tear, they do not heal. Tears also get larger over time. And so when you follow these things over time, for people who have tears, if you follow them over time, and roughly in about 18 months to 2 years, the majority of those tears tend to get bigger. The problem with bigger tears is that first it's harder to fix, but also the outcomes after surgical treatment of them get worse. And then as time goes on, there's also irreversible changes that can happen to the muscle. Just like any muscle that you don't use, they atrophy and they waste away. And that's the same thing with the rotator cuff as well. And so time is not a friend to rotator cuff tears. And again, as I was saying, numerous papers looking at this show that smaller tears do better, larger tears do worse. And so this is just an MRI, which is the most common study to look at rotator cuff tears. And, this is a picture showing some atrophy. The left side is a more normal rotator cuff. On the right side, where you see a lot more white, that's the fatty infiltration that happens to people with rotator cuff tears. So now you have a rotator cuff tear. How do you treat it? Some of the non-operative treatment options are here. And obviously one of the more common things that we employ is physical therapy if you have a tear, by strengthening the surrounding structures. You hope to help compensate for the ones that are torn. And in addition to all the secondary muscle issues that you have. So the physical therapy can be quite helpful. Different types of injections. Traditionally, cortisone used to be the main treatment, but nowadays we are really going away from cortisone. So there's been recent papers that look at the effects of cortisone even in arthroscopic cases. And it shows that if you had a cortisone injection within a year of having shoulder surgery, your chances of infection are higher, but also the chances of that tear not healing, requiring revision surgery, is also higher. And so there's clearly something with cortisone that's not healthy for the shoulder. And so by and large, I've been moving away from using cortisone for a lot of these issues. Platelet-rich plasma, or PRP, is another injection that's commonly used nowadays. It's still considered experimental. It's your own blood product though. And so we draw your own blood and we spin it down using a centrifuge to get a concentration of this substance. And we inject this into the shoulder. And this, I think, is maybe a better alternative now, given all the information that's coming out on cortisone. We can talk about this a little bit later. And then obviously avoiding aggravating activities, certainly chiropractic care and acupuncture are other viable non-operative treatment methods that you can do. And with physical therapy, there's new laser treatments and different things that have come out. And I think certainly you can give those a try if you're interested as well. And then, again, the upside with the non-operative treatment is that it's non-operative. You don't need to have surgery. The downside with this type of treatment for rotator cuff tears is that it's a temporary fix. It's not going to fix permanently the issues that you're having. And that's really when the operative options come in. In terms of an operative option, it's arthroscopic surgery or minimally invasive surgery. Again, the upside being that you are providing an anatomic solution to an anatomic problem, thereby allowing it to be a permanent solution. The downside being that you have to have surgery and get better, right? And so in terms of rotator cuff repairs, these are almost all done arthroscopically these days. There are pockets of people that still do open surgery, but by and large, most people have transitioned to arthroscopic or minimally invasive techniques where you take a tear and you repair it as shown on the picture. And again, the goal of this being restoration of the anatomy. You want a repair of your rotator cuff to result in a healed rotator cuff, thereby improving your function. And when you look at data for this, unfortunately, there's a significant re-tear rates for this. And a lot of these studies are a little bit older, but the trend has remained. Although we have gotten better, the bigger the tear, the higher the re-tear rates. And you look at the study from Lisa Galitz in 2004, that demonstrated a 94% re-tear rate, and they were bold enough to publish this study. But I think it just goes to show you that it's a continuing difficult issue to manage at times. And so that's where some of these new techniques come to play. And if you or someone you know of anybody that's been told that your rotator cuff is not fixable or it's irreparable, your tear is too big, I think these techniques can be actually quite helpful. One of which is called the superior capsular reconstruction, or the SCR. This was actually developed by a surgeon in Japan a few years ago and really popularized all around the world over the last couple of years. And the idea here is that you use, the specific population that you use this for are exactly what we talked about. Tears too big that you can't fix. And so for these patients, we use an allograft. It's an acellular dermis. It's a 3 millimeter thick piece of tissue that we actually use. And again, arthroscopically, in a minimally invasive way, we introduce that into the body and we patch over the defect. And we are not substituting this for a rotator cuff, but we are actually using it as a superior restraint, excuse me, of the shoulder joint to prevent it from going higher than it needs to. So what it does is it maintains the normal position of the ball and socket. Because without the rotator cuff, the problem is that the ball can tend to ride higher compared to the socket. By putting the superior restraint or the superior capsule, you prevent that, thereby optimizing the biomechanics of the shoulder for function. And so I find that this is actually a very helpful treatment for a lot of people with very difficult issues. And so you maybe know some people who've had it, but again, if you don't and you hear of people being told that there's nothing that can be done for them, think about this. This can help. There's now really no tears that you really couldn't do this for. And so there shouldn't really be anybody that's told that your tear can't be repaired when you can do an SCR for them instead. But because some of these grafts are more expensive, there's been more innovative ways to try to get graft material from inside the patient's body. And this is a technique that was developed in Asia as well, where you use your biceps tendon instead of using a graft to provide that superior restraint. And so I don't believe that this technique was published, but just due to kind of my contacts with Dr. Burkhardt's fellowship group, this is also a technique that I've been employing in some patients as well, where if you don't have access to this graft, which can be expensive, you can use your own biceps tendon to help augment any type of rotator cuff repair you have. And again, the concept's the same. big irreparable rotator cuff tears, you can actually help treat them by using these type of methods. And again, these are all done arthroscopically.
Hey, doctor, quick question on that. Would that be similar to doing like a bicep tenodesis and then using that material?
That's right, yeah.
Okay.
So you would do a biceps tenodesis at the same time, but you would leave some of the biceps, you keep it attached to the superior labrum, and then you pull it over and repair it to the tuberosity. And then you would tenodesis it distal to that. So yeah, it seems so simple, but someone did have to think about it. And I used that a few times here too in certain patients, and I think to good effect. I do want to talk about PRP as well. Just given all the negative headlines and studies about cortisone use, I really have gone away from using cortisone for a lot of different type of rotator cuff issues or even arthritis issues. I think there's significant downsides to them. And hopefully, as we get more and more data from plasma or platelet rich plasma use, it'll eventually be declassified from experimental to a more acceptable solution and treatment for patients. Most insurance companies still do not cover this, and that's really the downside with them. But in terms of its efficacy, in terms of safety, it's really hard to beat because it's your own blood that you're using. My experience with these have been actually really very good. And so I continue to use PRP where I can. And what I have done newly over the last year or so is for people with bigger tears. So as we talked about, the bigger the tear, the more likely that you can have a re-tear or poor outcome after surgery. And so for people with bigger tears, people who've had tears that have failed and is requiring revision surgery, or if at the time I determined that the tissue quality that we're trying to repair of your rotator cuff is poor, then I would actually offer this as an option for patients after surgery to utilize PRP to hopefully optimize their chances of success and improve the chances that the rotator cuff will heal. And so just again, something to keep in mind, just a subtle switch in kind of how I'm practicing, but PRP has become a lot bigger part of my practice. And I'll also throw in and say, I know there's stem cells that are now available. And I have to say, we have a lot less information on stem cell compared to PRP. And therefore, I continue to use PRP. And at least personally, given the kind of cost-benefit ratio of stem cells versus PRP, my preference really does remain with the plasma side, because stem cells usually are 10 times the cost without really kind of known added benefit as of yet. Okay, so I'll move on and talk about perioperative care. I think this is a pretty important topic as far as I'm concerned. When people come to see me, obviously they come to treat their shoulder. And, for those who end up needing surgical care, I view it really as more than just the surgery itself. And I think it's important to think of it as a very comprehensive care. And I think traditionally, maybe a lot of us have thought of arthroscopic or outpatient surgery as maybe more simple and, people understand what needs to happen and maybe haven't given a lot of thought and into how to treat patients better from this. But, I think I've really tried to do my best to ensure that patients have really good information, well prepared for the surgery by coordinating the care a little bit better. And hopefully we've improved on that. And I think, some of the experience from what used to be inpatient joint replacement cases, I think is helpful. As many of you know, when you get a joint replacement, whether of the knee or hip, the hospital often offers classes right? So you can get prepared to understand what you're going to meet and what you're going to experience once you have that joint replacement. And again, data is very clear. When people go to these classes and seminars, I think they feel a lot more prepared for what they're going to experience, and therefore their satisfaction level and their ability to deal with it improves as well. And again, that's what we try to do in the shoulder, where now I've actually offered this for, I believe, a couple of years now, where all of our patients are offered shoulder seminars prior to surgery so that they can be also properly equipped. Given the COVID thing, we haven't been able to hold classes anymore. When we were offering classes, you know, Ben or someone from his clinic or other physical therapists would also join us in this class so that they can offer their perspective to the patients as well. And again, I feel like it's been a very positive experience for most patients and even the therapists, because I feel like they feel like they're getting an opportunity to talk to patients that often come to see them. And they benefit from the patient's preparedness as well. But because we can't meet, we decided to upload an actual talk on my website as well. And so anytime anybody wants to have access to that kind of talk or seminar, feel free to access my website. And that talk is right on there, and you know, feel free to use that as you need to. And so that's been a big, I think, a big part of it. And then from pre-operatively to having the seminar to the actual operation, and then post-operatively where they're following up with the physical therapist, again, throughout that whole process, hopefully we've been able to do a good job of improving that coordination of the care so that the patients can experience a little bit more seamless care, and our PT partners and the physical therapy partners feel that we're, you know, hopefully communicating that kind of information better with them. The second part of this, I think that's been a big improvement over recent years, is also the pain management component. I talked to a lot of people and the expressions and reactions I get from patients when it comes to shoulder surgery often isn't the best. You know, people are scared of shoulder surgery because they hear horror stories about how much it hurts, how long it takes to get better, and things of that nature. But it often kind of centers around the pain part of it. And over the last few months, we've gone to using exparel blocks, which is a longer lasting pain release medication. And I feel like that's made a difference as well. And so we follow a multimodal pain management pathway where before the operation, there's a certain set of medications given. During and after the surgery, you're also given a certain amount of pain mediating substances to kind of help. And I feel like it's very rare when we have patients with significant pain that lasts what used to be fairly common in the past for weeks. The vast majority of our patients following this new pain protocol feel like are off of pain medication within a week. And then many of them require very little pain medication to begin with. And there's so many upsides to that. And I'll talk about them a little bit here. One is that when you have an exparel block prior to surgery, the benefits of that is that your body doesn't experience the same level of pain impulses at the time of anesthesia. And so because of that, you end up receiving anywhere from 30 to 40% less anesthetic gas and medication at the time of surgery. And that's a big deal for a lot of people, right? If you're having surgery and you don't need to get as much medication for the actual anesthetic portion of it, that's a big win, especially the older you are. You know, there can be effects on cognition and things like that under being under general anesthesia. I think that's a big win to begin with. Secondly, these pain blocks are not lasting just a few hours now. Most of them are lasting anywhere from 1 to 3 days, which is, again, the time where the pain is the worst. And now once you kind of come out of the block, most people pain are fairly well controlled. So it's a lot easier to control that with oral pain medication. And because of this, I feel like a lot of people's experience around shoulder surgery have improved. A lot of them are very surprised by how, manageable it has been. And so, again, another big, I think, part of advancing shoulder surgery, I believe, in the last year or so. Cryotherapy, this has been around a long time. We all know that ice can help decrease inflammation, and this is also offered to all of my patients as well. And a lot of them take this and use this as well. And I can tell you, a lot of people are very happy that they did. So what happens as a result? Clearly, faster recovery, right? Because if you're having less pain, then you're able to engage in physical therapy in a more meaningful way. Less anesthesia, we talked about the benefits of that. Less pain medication, again, the benefits of that is numerous, all of which hopefully leads to better outcomes. So this whole idea of perioperative care, pain management techniques, I feel like this may have been maybe the biggest advancement that we've had in the last year or so. So anyway, there's so many things to talk about as it relates to the shoulder, but I'll just kind of stop there, Ben. And if there's any further questions, of course, I'd be happy to answer them.
Yeah, there's a couple initially here, and that is large versus small tears. Are there different protocols that you prefer?
So, so smaller tears, as I talked about, they heal well. And so in terms of that, I am less concerned about re-tearing, and I am more concerned about people potentially getting stiff. It's a lot more common to have stiffness in smaller tears than larger tears. And so in general, I want early and aggressive passive range of motion. And again, depending on the patient, their age, and the exact size and tissue quality, I will start them on active range of motion a little bit earlier. If they're larger tears, though, or massive tears, then I approach them very differently, because the chance of a re-tear is a significant one, and that'd be catastrophic for the patient if it re-tore. So for those patients, I am very slow to move it. In terms of active range of motion, I'll start passive range of motion within a couple of weeks after surgery. But in terms of starting any type of active motion, it's a minimum of 12 weeks for me. And sometimes if it's a really massive tear or revision tear, I'll wait 16 weeks until we start strengthening. And so very different in terms of how those are treated.
Yeah, and I think one of the great things for the therapists and the patients or prospective patients on this webinar is that Dr. Koo does a great job of communicating very directly through his MA, through his PA, with the individual therapist and the team, so the therapists aren't left in the dark. And I think that's one of the bigger differences, if I was comparing against your peers, is that the communication level is very back and forth, very transparent. And I think the patients come into their first visit with PT knowing a little bit about what's gonna happen, and that there is a communication lines that are wide open. Another question here is, how many shoulder, if you have, I mean, you can make a guesstimate on this, but how many shoulder patients a year do you typically see?
So in terms of, you're talking about operations?
I think just, or maybe just patients that come in your office.
Oh, yeah. So last year we had, so Claudia is my PA, and we see patients together, obviously. And our total patient visits was 4,000 last year.
That's a lot of shoulders.
Yeah.
That's a lot of shoulders for people out there. This is a really timely question, and we'll wrap up here soon. I know you got things to do as well. as far as the COVID precautions, I think those are very well stated on your website. People can kind of read into those and read into what Perioperative is doing as well. But if you're a patient making a decision, the viewer asks, would you rather have the surgery now during COVID, or would you rather wait? Which we don't know how long we've been waiting, but.
Yeah, that's a good question. And that's some of it obviously depends on exactly what it is. So if you have a full tear of the rotator cuff, and if it's of any size, there is some time sensitivity to that particular issue, right? The longer you wait, the bigger the tear, the more atrophy. We talked a little bit about that. And so I'd be hesitant to wait too long on those. And COVID at this time is really not very well controlled in the United States, as you know, many of you probably already know. And I think the likelihood of it worsening over the winter time is probably pretty good. And so I'm not sure that, you know, I would maybe put too much of COVID related things too much into the decision making of if you're going to have surgery or not, if you have a time sensitive rotator cuff issue. At this time, at least at an outpatient surgery center like ours, every patient that undergoes surgery is required to have a COVID test. And so, and safety precautions are always undertaken to minimize the chances of any COVID spread. So patients, at least at our surgery center, every one of them has had a negative COVID test within 48 hours prior to having surgery.
And I would just piggyback on top of that, and I would kind of second that, is that something to keep in mind too for prospective patients out there is knowing what your healthcare coverage will be after COVID. So I think it's someone who's, you know, dutifully employed and has great insurance right now. You know, hard to say what the economy kind of does. So I think besides if you have a large massive tear, epidemiologically and, you know, physiologically, being smarter to probably have it done sooner, but also, you know, looking at the big picture of like what's the insurance mix look like for you on the back end of COVID. So if you're going to wait all the way to the end of COVID, hard to tell, like for many people will kind of be. One last question. I think this will be a good one to wrap up on. It kind of falls in line with some of the COVID questions in general, but that is individuals with comorbidities like diabetes, stroke, or other diseases. How does that affect the rotator cuff healing?
Yeah, so the older you are, the less chance of healing that you have. I think most people just kind of intuitively understand that. Comorbid conditions also can affect that. And those are most related to things like systemic arthritis, those things like rheumatoid, because those patients often are on steroids or on anti certain types of medication that prevent healing. Diabetes is another one that's fairly commonly known as posing a little bit more trouble in terms of healing as well. And so, yes, those are all factors that would negatively factor into your rotator cuff healing experience.
Awesome. Hey, well, I want to thank everybody for attending. Again, if you have questions, you can still email me after the webinar. I can pass those on to Dr. Koo. We will be posting the whole lecture on YouTube as well as reposting it onto Facebook as well, and getting that information out there to folks. Appreciate you people coming, and I think a large of you have attended both of the webinars, so I appreciate you taking your lunchtime to kind of do this sort of thing. It definitely helps fulfill the gap of us having our educational work. We would do our lectures on site. So I appreciate Dr. Koo and Jennifer for kind of helping set this up, and look forward to seeing you soon. We truly appreciate it.
Thanks, Ben.
All right. Thanks, everybody.